عايزين مرة التندنسي عايزين وضع بالنبر ماشي.
طيب ما يكفي.
لا عشان دي في داخلة في البروجكت.
طيب
بسم الله. نبدأ؟
بس عشان نطلع في اليوتيوب نوزعها على الناس.
بسم الله. السلام عليكم. Today inshallah we'll discuss sepsis campaign who makes the new recommendation 2021. The most important thing we should know that we are doing this lecture because this is one of the first recommendation of this campaign to do orientation and to give the new update to through an hospital program. The most important thing in sepsis is time to predict light, in simple word, light symptoms of sepsis. Because if we are not detecting sepsis very early, the cost and the prognosis will be very poor. Simply كده they are, when sepsis is happening, there will be hypoperfusion to the tissue. So oxygen will be less to tissue. So they will start to use lactate. Lactate, like glucose, there is normal level. It is not bad things. But extra lactate is bad things. For example, we are the myocardial muscle is using this lactate in stress in metabolism. So and also very high lactate level. This also giving a poor prognosis for the condition. The sepsis recommendation, as we say, is the first recommendation for hospital and the health system. We recommend using performance improvement program of sepsis. وده اللي احنا بدأنا هنعمل حوالي we will do 5 lectures or 6 lectures between ICU and the pharmacy and the surgical, because most of the cases we are dealing with related to sepsis in our hospital is surgical, but 50% of the cause of sepsis related to medical pneumonia. This one will be the main things we are using for improvement in our hospital. Usually we are using quick SOFA score in the ER and the SOFA score in ICU and ward. But the recommendation, they was using this quick SOFA score. Then the national early warning score. The last thing they are using now, we will not go into the details. Dr. Kamran, inshallah, in his lecture will go into these details. They are using, and this is the SOFA score. This is the search criteria. This is the national early warning score. This is the one we have to, inshallah, we discuss with the sister Eleanor, that will make the competency about this score. This score, modified early warning of sepsis. This is supposed to be in every department, especially nurses and ROD. Here ROD is ER. And we will inshallah print this and will be distributed, because this will help us in early detection of sepsis. Third recommendation for adult who suspected to having sepsis, which is suggesting, as we say, measuring blood lactate. Number four, a recommendation immediately treatment. In other slides will come once we suspect that this patient is sepsis, we have to within 3 hours to strict follow-up for investigation and the whatever required to reach the decision this mostly sepsis or not. And this antibiotic and resuscitation should start within these 3 hours. For example, this patient may be sepsis. I will not leave this. I will ask for ABG or VBG and I will go to be busy with other things. Supposed to be within 3 hours to finish this issue. Number five, this as we all know, this is not a new 30 ml per kg intravenous IV crystalloid fluid should be given within the first 3 hours, but albumin should be normal. Albumin will not be 14 and will give crystalloid. The number six in suggestions in dynamic measures guiding fluid resuscitation. We will not use only measure BP, MAB. We can go to inferior vena cava filling. Also, they are writing we can go to even echo. We was discussing with Dr. Akmal morning what is the use of echo, but we will distribute the link. In this link we will have this campaign, and you can read the details. They are recommending sure to use lactate level in follow-up. Other septic shock, capillary filling also is one of the clinical. They are recommend to continue using capillary filling in monitoring or measuring the perfusion. This 1, 2, 3, they are giving recommendation about 96 recommendation. So in my lecture, this part 1, I will take 36 recommendation, and then Dr. Salem will take another, and Dr. Sabir another, till they will finish by the end of this week. Admission to ICU, this is one of the most important thing. I have to evaluate the patient within 3 hours. This is sepsis or not sepsis, and if the patient need to admit to ICU, hereby the problem in needs. Maybe the patient is not hypotension. Maybe the patient, but there is other issue related. For example, if lactate is 7, lactate is 8, this patient need a lot of IV fluid. This patient already we measured the inferior vena cava filling and found patient. So better early admission to ICU, not to wait. Not to say he seems to be okay, we'll give him this and we'll wait. If patient diagnosed as sepsis and hypoperfusion, better to admit early to ICU. They are talking about 6 points about or 7 points about antimicrobial recommendation. The summary of this: if you are having the suggestion and the investigation that tell you this patient nearly sepsis, we have to start antibiotics and daily re-evaluate the condition. If we don't know this is the cause of this hypoperfusion, is sepsis or not sepsis, we have to look for other causes. If we look for other causes and found strong cause not related to sepsis, better to discontinue the antibiotic. For adults with possible septic shock and high sepsis, we recommend administering antimicrobial immediately within 1 hour recommendation. Also related to the same, always you will find we recommend rapid assessment like wound infection versus non-infectious cause. For adult possible sepsis and without shock, we suggest time-limited rapid investigation. This is what I was saying. Within 3 hours, to be sure by investigation or highly suggestive if this is sepsis, to start antibiotic within 3 hours. But if we are sure this is sepsis, we have to start antibiotic immediately. Related also to the same issue for adult low, here what I said before. If low likelihood infection and without shock, we suggest deferring, يعني to stop antimicrobial while continuing to closely monitor to the patient. The new recommendation related to antibiotic, not to leave the antibiotics for 14 days, 21 days, daily reassessment. And once you have uh, reasons to not continue antibiotic, you have to, as you say, deferring the antibiotic. The same thing we will discuss before. Here, for example, patient coming for another hospital like diabetic foot, he was admitting for, once you have suspicious that patient maybe have MRSA, you have to start the empirical antibiotic for MRSA. If this low, any patient not coming has a history of for 3 months to admit, better to not start. This, if we have multidrug resistance organism, and if the patient, for example, diabetic foot, I'm speaking about diabetic foot because we have this patient a lot, and already this patient admitting to many hospitals, receive a lot of antibiotic. Better to start 2 gram negative antibiotic. The second one, if not suggest, don't start these two. So in antibiotic, if I am sure or have highly suggestion, I have to start immediately. If I am not sure, within 3 hours investigation, I have to say I will start or not start. If the patient coming from other hospital and many admission, we have to MRSA coverage. If the patient I have suspected for multidrug resistant, I have to give him a 2 gram negative organism. Okay. Fungal infection, يعني if يعني with sepsis يعني if the patient with severe sepsis or septic shock, high risk for fungal infection, we suggest using empirically antifungal therapy. But if not, we are not suggesting. For antiviral, no recommendation, except I have here something that the patient has a viral infection, and this complication related to, to viral infection. They are recommending to give bolus beta-lactam and continue by infusion. For adult with sepsis and septic shock, they are suggesting prolonged infusion of beta-lactam for maintenance after an initial bolus. This better than intermittent every 8 hours or every 12 hours. Also, they are, يعني this is related إن شاء الله دكتور pharmacist دكتور رضا حريقة will discuss this إن شاء الله maybe in Wednesday. As we say, surgical and the medical and the pharmacists are sharing in the same thing. This what we was saying before. In adult and having sepsis and septic shock, we recommend rapidly identifying and excluding the anatomical and diagnosis of infection. And we have to look for the source of sepsis. Last thing in this issue, we should review daily for intravenous access. And I think in our hospital we are following this bundle about for duration of everything. But if you are suspecting, you have to remove this, especially for us for central line. This what we said before. We have to reassess every day the need for the need to continue antimicrobial, uh, and we are not saying that we will give for 15 days, while 21 days, while 14 days. Same thing. Uh, This something there was some recommendation before when you want to start antibiotic. I have light symptoms and I don't know this is sepsis or not sepsis. So I will use this serum procalcitonin. If it is high, I have to start antibiotic. They are now against this suggestion, but discontinue the antibiotic. We can depend on the level of the serum level of a procalcitonin. If it is start to decrease or became to the normal, I can stop the continuing the antibiotic. For other things, this always was controversy. They are recommend using crystalloid as first line of resuscitation, but again, albumin should be within normal range. Also, this crystalloid now they are not. They want to start balanced crystalloid. يعني ringer lactate is better than normal saline in resuscitation because it containing potassium, just not containing. So yeah, they are recommending balanced a crystalloid. Here, as we are saying, if you are using a large amount of crystalloid, we can use albumin, even albumin nearly normal. But if not, albumin is not normal, we have to correct the albumin during we are giving this crystalloid. Last 2 points, they are against using starch in resuscitation and also gelatin in resuscitation. What we will gain from this important previous point. First point, we have to orient our in this week. We have to orient. This is a recommendation from this sepsis campaign. We have to orient our charge nurses, and charge nurses will orient the staff with them also in ER and other department about that we have to detect and reach this is sepsis or not sepsis with this within 3 hours investigation. Second thing, we will use the modified early warning score. This modified early warning score will be in all the department. Our nurses will help us in this very well. Once the score for the patient will reach 4, they have to inform me the ROD. This is related to our hospital because no ROD for each department. Most important message is that sepsis is a complex, can affect any system of the body because sometimes patients are coming sepsis, for example, he has abdominal and he has peritonitis, has diabetic foot. Once another organ will be affected like lung, we will not say this is pneumonia. This is a multi-organ affection due to the sepsis, whatever the source of the sepsis is what. Okay. Second thing, we have to ensure if we ask for any investigation, why we are asking for this investigation, and to follow up. And I will ask for a VBG. I have to wait for this VBG and see serum lactate is high or not high. I have to compare this serum, this VBG, not this VBG, the other VBG before that. This lactate or these other things stepping up or stepping down, because sometimes we are asking for investigation and nobody reviews this investigation except late. One, this is known from before. The higher the level of lactate, the poor the prognosis. And our job now to prevent this lactate level to reach to reach a higher, so the prognosis is how by the early detection of sepsis. Last thing, dealing with sepsis, we have to deal systematically and the A, B, C, D, E. As any critical case, we have to deal with acute critical care events. Yani, for example, now patient has crepitation in his chest. So I will call Dr. Akmal. He will tell me this patient is going to pulmonary edema, and this patient his blood pressure is 70 over 50. That means I will not give him fluid. I will give him vasopressors. I will give him IV fluid, and if he need BiPAP, I will give him BiPAP. If he need intubation, I will intubate him, because patient alive with pulmonary edema in ICU can be managed, but patient, if I will not give him IV fluid, and this one of the most important points they was hammering in, and when we take the course of Canadian Royal College, deal, and they bring to us cases, يعني demo يعني patient low urine output, pulmonary edema, and hypotension. What you will give him? Some will say Lasix. We have to give him IV fluid. A, airway. B, breathing. C, circulation. Circulation means if the whatever the condition of the lung, his pulmonary edema, I have to give him to resuscitate by fluid and vasopressors. Okay, and I have to again to follow A, B, C, D, E, because many times in ER we found patient shocked, and we are afraid from pulmonary edema. We are not giving fluid because of pulmonary edema. We can give him and we can intubate him. Inshallah, tomorrow will be the second lecture will be by Dr. Salem. We'll continue from 36. Thank you, Jama'a. Shukran.